Left myself muted there. Sorry about that. Can y'all hear me okay?
We
All right,
can.
and you can see it.
Yep.
All right. So my name is Rachel Mitchell. I am a pharmacist here at the WV Medicine Specialty Pharmacy. And what I'm going to go over is some drug-drug interaction, common drug-drug interactions that we see with our hepatitis C direct-acting antivirals. And there was a special request for us to talk about the co-infections for hepatitis B and TB that some of y'all seem to be seeing a lot more frequently. So I went ahead and incorporated some of those in here as well to go over. So, and most of these that I have picked are things that I see commonly from an interaction standpoint. So I threw in here a lot of information, hopefully valuable information in a visual format with charts, and just some of the recommendations and suggestions that I've worked with other providers to try to overcome some of these drug interactions because common things are common and they're going to happen. We're going to see them. So I'll start with the statins, which is this is the very colorful slide. So what you can see, at least at a glance, is that when you look at your direct acting antivirals and the components in those, our biggest issues are going to be drug interactions with those agents that also have protease inhibitors in them. So just like in HIV, protease inhibitors tend to mess up metabolism of medications. And what we're worried about with the statins overall is that a lot of these agents in the direct acting antiviral class will inhibit the metabolism of the statins, therefore increasing their concentrations and increasing our risk of toxicities. And what we're most concerned with is the myopathies and potential to progress towards rhabdo. So hopefully this is a quick reference that you can kind of color code and look through. Some of the agents have specific maximum recommendations in terms of their dose concentration of the statin when given in conjunction with the direct acting antiviral. Some of them are contraindicated altogether, and some of them have this suggestion of lowest dose necessary and monitor. I don't know what that means when they say the lowest dose necessary, right? Because it's a statin and you're giving it for a reason. So what is the lowest dose? So I don't have a recommendation, and I generally don't have a recommendation to automatically lower the dose for the ones that say that in the package insert. And most patients do really well when it says lowest dose, and we do monitor, just educate them on what those risk of myopathies look like and feel like, and when to report to you so that we can make alternative switches at that point. But looking at this chart, you've got max doses, so you can reduce their dose. So as an example, if you're going to utilize Mavorite patients on rosuvastatin, so long as they're on 10 milligrams or less, you're good to go. If they're on a higher dose than that, you can lower it. Your other option is that you can select a different direct acting antiviral for any of these to avoid any interactions. You can always lower the dose of your statin. You can completely change the statin. Or if the patient doesn't have a significant cardiac history where you're concerned, they can just hold the statin and not take it for that 8 to 12 weeks while they're on their hepatitis C treatment. I see that pretty common in patients that have a stable cardiac history and they're not concerned. So they can just hold it for that time period. So you've got some options and some wiggle room that we can work around with the patient just to do that education. The next group is another big group that I see, and that's acid suppression. So everybody seems like they're on PPIs or H2RAs, some sort of acid suppression. So the problem that we run into are going to be with Harvoni and Epclusa. So the easy way to remember this is that they're your sofosbuvir containing agents. So they're both sofosbuvir and another NS5A inhibitor, but the interaction is with the NS5A inhibitor. So lidipisphere and velpatasvir respectively. And what happens is that as you increase the gastric pH, which is the goal of treatment with these agents, as that increases, the solubility of your DAAs decreases. So it's not dissolving, it's not getting absorbed, and then we end up with subtherapeutic levels. And the concern is virologic failure where they don't achieve cure because the levels aren't high enough. And then we end up with some sort of resistance as well, just because of those subtherapeutic levels. So again, you've got some options. You could use something like Mavorite or Zepitir that is an alternate DAA where I don't expect these interactions with acid suppressing agents. If the patient is willing, they can also hold that agent and not take it for that 8 to 12 weeks. The other option, which is on the subsequent slides that I'm going to go over next, is adjusting the dose and the administration of the acid suppressing agent with the Harvoni and Epclusa. So I've got this broken down into two different slides. The first one is focused on Harvoni. So I've got the levels of the acid suppression over on the left-hand side here. So you can see antacids at the top, because they have a short duration of action, don't hang around very long. So long as you separate your Tums, your Maalox, your Rolaids from Harvoni by at least 4 hours, that'll avoid the interaction because it's not going to stay in there. It's not going to have that duration of effect longer than that 4 hour period of time. So long as it's greater than that, the Harvoni should be just fine, dissolve just fine, absorb just fine. The next level is your H2 receptor antagonists or H2RAs. So here is where it gets a little more complex in that we have max dose recommendations and appropriate admin instructions for these to avoid the interaction. So the recommendation is a max dose of famotidine, which is Pepcid, 40 milligrams twice daily, or comparable dose. The comparable dose is ranitidine, should it ever come back to the market. So I've left that on here just in case. But 40 milligrams twice daily. And when they're giving the Harvoni, it's either got to be taken simultaneously or 12 hours apart. So really what you're looking at is, are they taking it once or twice a day? If it's once a day, they could do it at the same time or separate it. If they're taking the Pepcid twice daily, at one of those administration times, they're also going to have to take the Harvoni. And that should avoid the interaction and give us the least amount of that drug interaction so that we don't lose our efficacy with the Harvoni. The next layer, a little bit more complex, is with your proton pump inhibitors or PPIs. So you've got your omeprazole 20 milligrams as your max dose, and they did do some studies. So they have the comparable doses suggested in the package insert that you could utilize as well when given with Harvoni. And the recommendation there is to take them simultaneously under fasting conditions. So no food in the stomach, taken on an empty stomach, take them at the same time every day. So those are your recommendations with Harvoni. A little bit different with Epclusa once you get to the PPI. So you can see acid suppressing or antacids, same recommendations as Harvoni, H2RAs, same recommendations. With the proton pump inhibitors, they did some PK studies, some pharmacokinetic studies to try to see when the best administration time was with Epclusa to make sure to avoid that interaction. They did not study it with anything outside omeprazole. So package insert, your legal information, that says omeprazole 20 and no other comparable doses. It wasn't studied. So if it is medically necessary that they be on a proton pump inhibitor while taking Epclusa, it's omeprazole 20 or bust. And then the admin instructions are to take the Epclusa with food and then take the omeprazole 4 hours later. And what I find often from when I'm educating patients and trying to give them an information is that it's really beneficial at this point to provide them with a schedule, because sometimes they hear 4 hours later and they think, oh, it's just like the antacids where it's separate by 4 hours. And I will say there's a deficiency in the language of the package insert in the patient education portion where it says antacids and it does say at least 4 hours. So patients assume that a proton pump inhibitor meets that criteria, and they get a little bit confused with that 4 hours when they read that information in the package insert. So I try to set up a schedule with them so that they know what that really looks like. So if you're a morning person and you want to take the Epclusa in the morning, take it at 8 o'clock, take it with your breakfast, and then don't take your omeprazole until noon. And it's noon. It's not 2, it's not 4, it's not 8 p.m. Take it at noon so that they know that that is a strict 4-hour requirement. Because again, that's when they did the PK studies and they saw when is this interaction going to be the least issue. And it was that 4-hour window separation when they did it. So that's where the recommendation comes from. And if you go and look at those studies, when Gilead published that information for both Harvoni and Epclusa, that decreased the area under the curve and the concentration for those drugs once the pH is above 4, again, the goal. Once that happens, then it's a decrease in about 60-ish% of the drug. So it's a pretty significant decrease of the drug once that pH is too high. All right, so I'm done with my acid suppression rant. We'll move on to ethinylestradiol here. So this ethinylestradiol is the estrogen component of most of the over-the-counter oral contraceptives, as well as a handful of hormone replacement therapies. So that's going to be our major interaction here that I see is most often going to be in contraception. Originally, this drug interaction was found by a different AbbVie product than Maverit. It was with the Vicira, which I don't even think is in the guidelines anymore. It is still available, but I don't think it's used. I haven't seen it in a while. but it was found with that product first, and then they also noticed it with Mavyret as well. So it used to be the recommendation is if they're on an ethanoestradiol containing medication, it's contraindicated. Within the last, I think, year and a half, maybe 2 years, they did some follow-up post-marketing studies and found that there is a safe level of ethanoestradiol in those contraceptives that we can still administer these together. So if it's 20 micrograms or less, you can administer them safely together. It's those higher estrogen containing contraceptives that are greater than 20 micrograms where we have that concern. And that concern is an increased risk of ALT elevations. So that at that point, the co-administration is not recommended. So again, from an option standpoint, you could not use Mavyret and use a different agent that doesn't have the interaction. You could have them hold the ethanoestradiol containing product. I don't love that idea just because we still don't have a lot of great data where we're comfortable with these agents in pregnancy. So we don't want to tell them to not use contraception at that point. They could also use a different product. So if they're on a higher than 20 microgram product and they're willing to switch to a lower than 20 microgram product, you could do that. We have a lot of progestin-only contraceptions that we can use, any of the long-acting ones. So if the IUDs are drug-eluting, progestin. The Nexplanon implant is progestin. Depo is progestin only. Of course, there's the mini pill, the progestin-only pill as well. So you've got a lot of progestin-only components that are safe, or abstinence or alternate contraception, which again, weigh in your risk benefit there of not having contraceptive if the patient is sexually active and at risk for pregnancy while on treatment. So I don't love that recommendation, but you do have some options if your patient is taking something with ethanoestradiol in it. All right, some antiarrhythmics that we see. Our biggest concerns are going to be digoxin and amiodarone, which are problem children from a pharmacologic standpoint anyways with antiarrhythmics. Your biggest issue with digoxin is going to be Harvoni, Epclusa, and Mavyret. And as you're probably already aware, digoxin has a real narrow therapeutic index and weird metabolism. So small increases have big impacts on concentration. So when it comes to digoxin, really it's just extra monitoring, get their dig levels, get them more frequently so that we can make sure that they're not having toxicities related to that digoxin. If you look at the United States package insert, it actually has a recommendation for Mavyret specifically to automatically reduce the dose by 50% and then monitor the patient from there. So that's a major concern with digoxin and those three agents. Zepatier, though, doesn't have any adjustments or additional monitoring per its package insert. The other issue is going to be amiodarone, and that's with your sofosbuvir containing regimens. So what this drug interaction is, I have no idea the specifics of it. I don't think we've come across the why, but what happens is we found post-marketing. So this did not come up during the clinical trials, but post-marketing, there were several cases of patients, including one fatality where they had severe bradycardia. There were even some cases where patients had to have pacers placed. So this is, again, with your Harvoni, Epclusa, Vosevi, because they all contain sofosbuvir. So one of those things to always remember with amiodarone is that it has a crazy long half-life that is often quoted to be somewhere around 60 days. So when do you start one of these agents after you stop that? I don't know. So back in the day, before we had alternative regimens, we guessed and would wait a couple of months, usually at least 5 months before starting these agents after switching them from amiodarone. So you can do that. There is some information in the package insert about admitting the patient and then doing cardiac monitoring. I don't know what insurance is going to pay that or people that are actually willing to go in the hospital to start these medications, but that is what's recommended in the package insert. So when it comes to this drug interaction and when it happens, it's usually within that first day. Hours to days is when we've seen the bradycardia occur, but there are delayed reactions that were reported that could take up to 2 weeks. So the recommendation is to use a different agent that doesn't contain sofosbuvir, or you could change the amiodarone, but always caution, amiodarone lingers for a long time anyways, and it's also hepatically eliminated. So if your patient has some hepatic dysfunction, that 60 days is going to be even longer. So that's going to turn into an even longer delay following their switch from amiodarone before you could start them on Harvoni, Epclusa, and Vosevi. So probably the easiest thing, provided there's no other drug interactions or concerns, would be to use a Mavyret or Zepatier that doesn't contain sofosbuvir. All right. This is the easiest slide to make because it's just one color across the top here. So your anticonvulsants, primarily the carbamazepine, oxcarb, phenytoin, and phenobarb that are across the top here, are all enzyme inducers. So this is primarily your cytochrome P450 metabolic enzymes, as well as P-glycoprotein, which is an efflux pump. So you're chewing up the drug faster and evicting it from the body faster. So all agents, all the DAAs that are commercially available, their package insert says do not co-administer these. So I've left all these ones here on that are in green because there are some options. So if you are able to switch them from one of these top four agents to one of the agents in green here on the bottom, that could be a good option. I do realize though that sometimes that is hard because if these patients are taking them for seizures or if they're using them for another reason for mood stabilization and other things, sometimes they may not be willing to switch, or if it's a neurologist may not be willing to switch them. So that gets a little bit tricky. But the problem from a medical legal standpoint is the package insert does say don't do it. But that's why I have this on here, more data soon. There is some very limited data that has shown some success with treating patients that are on these agents that do not have the opportunity to switch and taking a DAA and actually achieving cure, because that's the hard part that we're stuck in, right? Because if they can't switch for whatever reason, they just don't get treated. Like, is that our option? So obviously we're not okay with that. So this is a table, and I've got the citation here for this article of, it was a series of case studies that was in the Journal of Pharmacy Practice. So you've got 5 total patients, and they treated them with mostly what you can see on here is Mavorite. One patient had Harvoni, and they all achieved SVR. They did not alter the doses of any of the direct acting antivirals. It was standard dosing, it was standard treatment duration. They did do drug levels and things throughout here, but the patients were successfully treated and achieved SVR. So I'm hoping this is going to move us toward knowing whether or not this is safe, or at least getting us a little bit more data. Because when you look at it's do not recommended, and this is all the theoretical stuff, right? Because we know they're enzyme inducers, we know there are drug interactions with a lot of drugs, but they didn't actually study them, the direct acting antivirals, with these anti-epileptic drugs. So we don't have that serious data. So now we have a little bit. So the cautionary tale here is that what you can see is it's 5 different patients, a smattering of the different anti-epileptic drugs, mostly Mavorite, but one Harvoni. So Epclusa and Zepatier are not represented here, and they are all genotype 1. So mostly 1A, one patient is 1B. So we can't extrapolate that everywhere, right? That's limited data. There was also a study, this is from 2022. There was a study done in I think it was 2019, that that group looked at anti-epileptic drugs and then giving a combination that we don't use anymore, sofosbuvir and declatosphere, brand name Declinza, which is no longer on the market. And in that study, what they did was look at higher doses of Declinza, because Declinza was actually a drug that had a lot of interactions with HIV medications. So as it was marketed with multiple strengths and higher strengths to overcome the drug interactions with the HIV medications. So they used that to their advantage in that study and gave higher doses of Declinza to see if that would overcome. So that was also something they did in the past, but Declinza's not available on the market anymore. So this, I think, the reason that I highlight this on the slide and didn't have the other one is because at least this one's a little bit more real world, and agents were able to use at those standard doses. So my hope is that we'll continue to have these case studies and maybe get some funding from some of the drug companies to do a bigger study so that we have a better option for these patients, rather than you don't get treated, or you have to take a drug that doesn't work for you in the interim while you're getting treated for hepatitis C. So hopefully more to come on that in the future. But again, the medical legal jargon is that it's contraindicated because that's what's in the package insert. All right. And then other good news for antidepressants and anti-anxiety medications is that by and large, we don't see a lot of drug interactions. So a lot of these patients may be on SSRIs, SNRIs, taking benzos, or on tricyclics. So in this case, no expected concerning drug interactions with any of the DAAs and those classes at large. So good news there. And then this slide here is the antipsychotics. And I don't know if Angie has hopped on, but Angie from RDT actually made this slide and it was beautiful and perfect. So I asked to borrow it and I didn't need to remake it because she already did the hard work for me. So this is hopefully another good, quick visual to be able to see what direct acting antivirals may have interactions with some of the antipsychotics that are on the market. And what you can see across here is that there are no contraindications with any of these. They're all yellow, and the concern is increasing the direct acting antiviral, increasing the concentration and therefore risk of toxicity with some of the antipsychotics. So in this case, what I usually do from a counseling standpoint is just go over some of the things that we may see with the different agents. Like if it's got a risk of sedation, they may see more sedation, CNS depression, those sort of things. The long-term stuff with antipsychotics and in terms of some of the extrapyramidal effects and metabolic effects, that I'm not concerned with because this is just going to be 8 to 12 weeks of treatment. It's really those more acute sort of toxicities that we would be concerned with, like that CNS depression and things. But again, I just educate patients and follow up and see if they're having those sort of side effects or concerns from the interaction. And most patients do really well. I haven't had any, knock on wood, that I can remember that it's been a real major interaction that we've had to make any changes in the middle of their course of therapy. All right, next up, we've got anti-coag and antiplatelet medications. First one, always got to throw in warfarin. I always say warfarin is voodoo. It's more of an art than a science when it comes to dosing warfarin. The issue here is not that the retroacting antivirals have an impact on the metabolism of warfarin. Really, the issue here that we see some alterations is just to all the other factors that we're concerned with warfarin. Could be that they have an improvement in liver function once the hepatitis C is cleared out. Could be that they feel better when I have a lot of patients that tell me, oh, I have more energy now that I've been treated for hepatitis C, and now they're working out more, which impacts warfarin, or I'm eating healthier, which impacts warfarin. So this is just monitor across the board as you would just if they have point of care testing at home or can get tested a little bit more frequently when they start therapy, just to make sure it's not going to have any crazy jumps. Most patients that I've seen with warfarin and taken DAAs do really well. A handful of them, their INR is dropped and we've had to make dose adjustments, but just that monitor, no contraindications, no one agent over the other. When it comes to the 10A inhibitors, this is just a monitor for bleeding. This is kind of like the lowest dose necessary for statins. Like, what do you monitor? So just re-educating patients on, when is a bad bleed that you need to have looked at the hospital to go to the emergency room, signs of, brain bleeds and that sort of thing. But really you don't do 10A monitoring for these patients. That's not part of the recommendation. And there have been subsequent post-marketing studies in the last few years that have looked at patients treated on DAAs and taking one of the 10A agents. I think in this study, it was primarily apixaban and edoxaban. But what they found is that the occurrence of bleeds in patients taking DAAs with these meds was the same as what they would be with the meds alone, with the 10A inhibitors. So they don't scare me in terms of drug interaction. So it's just a monitor just in case. The only one that is red on here is dabigatran. And with dabigatran, and I have like the not recommended / adjust dose, and it depends on whose package insert you're looking at. So if you look at the European package insert, it's contraindicated, not recommended to give those together. In the US package insert, the recommendation is that you can give it together. It depends on the patient's renal function. So if they have like a normal renal function, you don't need to adjust the dose. Once it goes down to 30 to 50 mLs per minute, then you do the reduced 75 twice daily. And then if it's severe renal impairment less than 30, then at that point, it's contraindicated. So it's based on their renal function and how important that interaction is. This table I also did not make. This is a screenshot from the guidelines. So in their HIV section, they have this nice table already created that goes over the antiretroviral agents and the recommendations with the different DAAs. So again, you've got options here depending on what your patient's HIV ART regimen is to be able to select a DAA or make some modifications if needed. Again, protease inhibitors at the top interact with protease inhibitors, and we use that to our advantage in HIV, right? We boost regimens with those. So that's where you're going to see most of the red up there is because the protease inhibitors are going to interact with each other from the different classes. And then the yellow highlights the sofosbuvir agents with those. And I have the legend over here. A lot of the issues with those A's as well as the B's and C's that are throughout here is going to be your increased levels of tenofovir, primarily the TDF formulation of tenofovir. So in the protease inhibitor section, it's because those boosted regimens with the direct acting antivirals will increase your TDF, as well as some of the other options here that you see with the boosting, the integrase inhibitors, and just the TDF down at the bottom portion of the screen. And what we're really concerned with there is renal toxicity that we already saw with TDF, and then increasing the concentration with the sofosbuvir is going to increase that risk. So that's our biggest concern there, is just monitoring the patient more frequently if you're going to give them TDF. The other option is to switch formulations and use the alafenamide or TAF formulation of tenofovir, where we don't have that concern just because of the way that we altered the pharmacokinetics of that drug to not have the concern with toxicity with the renal toxicity. All right, dovetailing into hepatitis B antiviral medications when given concomitantly, there's a lot of good news here because a lot of it is green. Our major concern here is going to, again, be TDF. So you can use the TAF formulation if you so please. And so tenofovir and entecavir are probably going to be your most common orals. Can use PEG interferon. I put lamivudine on here for completeness, but I don't think we use that anymore just because of our risk of resistance. But if you're concerned about drug interactions, TAF and entecavir, you're good to go in terms of co-administering hepatitis B medications with hepatitis C medications in those folks that are co-infected. And then next here, I've got your TB medications. Lots of red at the top because those are your rifamycins, probably in every package insert, because rifamycins as a class are enzyme inducers. So what they're going to do is chew up the direct-acting antivirals, and we're going to have subtherapeutic levels, risk for resistance, and virologic failure. So that's red across the board for all of those. Technically green for everything else, but the problem with isoniazid that I have with the asterisk here is that it does have a black box warning for fatal hepatitis. So if you have a patient with hepatitis that's already got some liver dysfunction, probably not a great idea to use it. And it's the only one that has the black box warning, but the rest of the three at the bottom are also pretty heavily hepatic handled and potentially toxic medications as well. So we've talked previously here in the echo sessions when talking about treating patients with TB after hepatitis C treatment, just to get rid of that hepatotoxicity risk there before treating for the TB because of that risk and concern with hepatotoxicity. So the bottom half doesn't technically have any drug interactions. The concern there is just more with the liver health overall. And when it comes to your medication-assisted treatment or MAT, you're good to go. Don't have any major concerns with any of the direct-acting antivirals and our MAT meds across the board. So that's an easy slide. I always like to highlight this drugs of abuse slide in case your patients are still actively using. So on the left-hand side, you can see no concerns with any of the drugs listed here. Our main concern is going to be with fentanyl, GHB, and oxycodone because Mavorite and Zepatier may increase those in terms of concentration. That is a theoretical risk. And my main concern really from an education standpoint to patients is just being aware of what they're taking and any potential additional fentanyl or being laced with any products that would tip them over to that. I think that's really going to be more of a problem for them than that theoretical potential increase from these agents when taken with the direct-acting antivirals, but that information is in the package insert for those. I always like to highlight herbal supplements. I don't know, lots of people like to take the herbal supplements. I don't like it, mostly because a lot of them have hepatotoxicity risks, so I do my best to convince them not to take it in general, but definitely not to take a lot of these when they are on hepatitis C treatment, because we don't have a lot of data in terms of drug interactions. St. John's wort we do. It's like rifamycins. It's an enzyme inducer, so risking virologic failure there. The little data that we do have for things like milk thistle melatonin, turmeric, and grapefruit juice, we don't expect any interaction. So if your patients are taking those, might be okay. I also want to highlight some really cool drug information resources or interaction resources for you guys. So LexiComp, if you have the subscription, the NIH in their HIV section has a nice little chart as well on HIV Hep C co-infection and looking at heart therapy and DAAs to see what is best for your patient. And then the University of Liverpool has this really nice app as well as a website, both of which are free and you can download those. So I've got the link here for the website if you want to go look, and just some screenshots from the app on my phone where from left to right, you pick whatever direct acting antiviral you want to double check. It will let you check multiple of them. So if you're not sure and you're like, oh, I want to look at both Mavorite and Harvoni, you can select both. Select your patient's medications on the next screen, everything they're taking, and then on the last screen, it gives you this nice little color-coded readout of any of the interactions that come up. And then if you click on them, rather than a regular drug interaction resource, it actually gives you that pharmacokinetic data so that you can make an educated guess and decision on like, oh, this is probably a real interaction, or I'm not sure, like this is just theoretical, I want to work around it. So it does give you that nice data. If you go to their website as well, they have the tables. I've got the link here. So if you don't want the app and you're like me and you like to surround yourself with paper, they've got the tables that you can print out so you can visually see a bunch of different drugs at once to reference. And if you're interested, the Liverpool websites, they have other interaction checkers for things like Paxlovid, they have Hep B. I think they have one for HIV as well. So they have other drug interaction checkers that are set up the exact same way. And of course, as I
Hey,
mentioned,
Rachel, you have two questions.
oh, okay.
Sorry. The first one was, what is GHB?
What's that?
What is GHB?
The interaction itself specifically comes from benzos, but gamma hydroxybutamine, I forget what the street name of it is. I'm
Okay.
gonna have to look that up.
And then the next one was, from a public health perspective, would it be better to treat TB before treating HCV?
To treat, say that again.
Would it be better to treat TB before treating HCV?
What we have discussed in the echo sessions before from a treatment standpoint is to do the hepatitis C first because the TB medications are so toxic, potentially toxic to the liver, that to treat that first to get rid of that sort of strike one of liver toxicity before introducing the patient to long-term potential for hepatotoxicity with those TB meds. So that's where that logic comes from, where it's not necessarily the drug interaction per se that's the concern, it's the liver health. So get rid of one toxin to the liver, the hepatitis C, treat that first, and then do the TB after that for like latent TB infections. Now, if your patient is really sick with an acute infection and that's the more acute problem, sure, I could see that. And I'll defer to actual prescribers on their input for that. But that's usually for latent TB infections. We treat the hepatitis C first, or at least that's what I've seen historically. That's a good question. Any other
Thank you.
questions?
Amanda Curry said that GHB, I believe, is the date rape drug.
Yes. I'm forgetting the roofie, right? Is that what it is now that you've said that? Okay. Thank you for that. All right. And I think all I had here was the guidelines for a reference in that monitoring section has some of the drug interaction stuff in it. So if you wanted to reference the guidelines as well for some of those charts like that HIV interaction chart, they've got some good interaction charts in the guidelines as well. And I think that's it.